Today I am presenting a case of orthopedic infection, which is a surgeon's nightmare because of the challenges involved in the treatment. Starting with the case, we have a 31-year-old male, resident of Ocean, Jodhpur, manual laborer. He suffered a road traffic accident where there was a head-on collision between a tractor and a truck, and he was sitting on the tractor in June 2012. He was admitted to MDM hospital with head injury. He was unconscious for almost 12 hours. He sustained a mandible fracture and an open injury to the left leg. Head injury was managed conservatively. After 12 hours of unconscious, he was fully conscious. There was no further episodes of unconsciousness. There was no further episodes of vomiting, and there were no focal neurological signs. Mandible fracture was managed with some kind of wiring after 5 days of injury, and the open fracture, which was possibly a type 3A or type 3B injury, which is a grading given by Gustello and Anderson way back in 1976, where there is 3 types of open fractures. Type 1 fracture, in which there is a skin wound less than 1 centimeter of size with a simple fracture pattern. Type 2, which has a skin wound of more than 1 centimeter in size, but the fracture pattern remains simple. And type 3, which is a high energy injury involving extensive soft tissue damage. Extensive soft tissue damage. Type 3 was further subdivided into 3 further types, type 3A, B and C, of which type 3A is an adequate soft tissue cover of bone despite extensive soft tissue damage. Type 3B, where there was a periosteal stripping and the bone was bare, and type 3C, which was associated with an arterial injury requiring an arterial repair. So, initially the open fracture both bones leg, as we can see on this X-ray, that this is the fracture of the distal third, which is distal third involving both the tibia and the fibula, and the proximal fragment probably jetting out from the skin. So initially it was managed with dressing and splintage, and only after 3 days of injury a formal debridement was done, and at the same sitting an interlocking nail was inserted. The wound could not be closed, so it was left open. The patient remained admitted for around 12 days in MDM hospital, after which he was discharged on oral antibiotics. The wound dressing was continued alternate days. At 4 months, the wound has healed by secondary intention, leaving behind a small discharging sinus. At 4 months also he was not able to bear full weight. So because of these, he sought a second opinion at Disa, Gujarat. At 4 months, this was the X-ray, and we can see on the AP and the lateral views that the fracture line is visible both on these AP and lateral views. So at 4 months there was non-union of tibia and fibula. At Disa, Gujarat, he was again operated with the removal of interlocking nail, and at the same time an antibiotic cement loaded V nail was inserted. In the same sitting, a chest fixator, which you can see it is applied in the distal part of the leg, and probably the reason being because V nail does not have any rotational stability which the interlocking nail has. So that was the reason by which this chest fixator was applied. After 1 month, this fixator was removed and the patient was advised full weight bearing. But since patient continued to have pain, patient walked with support, some kind of support. After 3 months, the nail was removed, but at the time there occurred a complication in which there was a debonding of the cement from the nail, and the cement remained inside the medullary canal while the nail was removed. So he continued to have persistent discharging sinus and continued to he was unable to bear full weight. So he presented to us in November 2013 with the complaints of discharging sinus and inability to bear full weight. On examination, there were 3 sinuses over the medial aspect of lower 1/3 leg, 2 inches above the middle malleolus, of which the middle sinus was actively discharging pus with protruding granulation tissue. As you can see, there is a healed area scar on the medial aspect which was adherent to the underlying bone. The knee was normal, the ankle movements were restricted, plantar flexion was 0 to 20 degrees, there was 1 centimeter of shortening in the tibia, and there was no distal neurovascular deficit. On workup of the patient, the inflammatory markers were slightly raised, hemogram was normal, pus culture sensitivity showed a coagulase positive staphylococci which was sensitive to levofloxacin, linezolid, minocycline and piperacillin plus tazobactam. On radiological examination, we can see that there are features of non-union. Even after 1.5 years of injury, the fracture line is still visible both on the AP and the lateral views. We can see features of chronic osteomyelitis. There is cortical thickening, there is irregularity of the cortex all around, which suggests that there are features of chronic osteomyelitis. And we can see a cement layer of cement inside in the medullary canal. Since there was a presence of a discharging sinus, we went for a sinogram. The sinogram to assess the extent of the sinus, as well as we can see that there is a pooling of dye inside the medullary canal around the cement, which suggests that the cement can be a source of infection. So the diagnosis which was reached was infected non-union of both bones like lower 1/3 with actively discharging sinus, with shortening of 1 centimeter in tibia, with infected cement in situ. So what do we do now? First thing is we have to assess what are the problems we have. We have an actively discharging sinus, we have a poor soft tissue envelope which has an adherent area scar, we have a fracture which has not united for the last 1.5 years, we have an infected cement which is present in the intramedullary canal, and we have a shortening of 1 centimeter. So is there any role of a conservative management? No. Since the fracture has not united for 1.5 years and the source of infection is still in the medullary canal, the only option left is surgery. So what we are going to do in surgery? The first step is debridement. We have to remove the entire infected and dead bone. We have to remove the infected cement from the medullary canal. Sinus tract has to be excised. Fracture edges has to be freshened. And there should be an intramedullary reaming and lavage. It may require a wound cover, either a flap coverage in the form of a gastrocnemius flap or a cross-leg flap, and then we have to stabilize it. Internal fixation in this case will be a risky proposition because of the infection, gross infection which is present. So the best option will be an external fixator. We have two types of fixator, either a ring fixator or a tubular fixator. The advantage of a ring fixator is that the patient can be mobilized full weight bearing immediately after the surgery. However, the frame is bulky, so the patient is generally not compliant. However, the tubular fixator, it has a disadvantage that it's a semi-rigid fixator and the patient cannot be mobilized. And it is generally used as a temporary measure, and patient generally needs some form of definitive fixation after some time. So a few things about open fracture. Open tibia fractures are generally associated with an infection rate of 6 to 33%, and the risk of deep wound infection increases with the severity of soft tissue injury. So as we have discussed the types, the type 1 is associated with 0 to 2% of infection, while type 3C, which is the severe grade, is associated with almost 50% of infection. Systemic antibiotics, they do have a role in open fractures, but when they have been operated with some kind of implant, their efficacy becomes limited. The reason being that there is a formation of biofilm over the implant surfaces, at which the microorganisms, the antibiotics do not act on that microorganisms. There is also a decreased blood supply which has been caused either by trauma or nailing. So in order to enhance the delivery of antibiotics at the implant tissue interface, local antibiotic delivery systems has been developed. The technique of delivery must guarantee a rapid, sustained release of the antibiotic from the carrier, and the drug levels reached should be well above the MSC of current organisms. The drug release must be restricted for a limited period, otherwise they can develop resistant bacterial strains. Bactericidal antibiotics are generally preferred in local delivery, and the carrier substance should be biodegradable. So what are the options we have? We have an antibiotic impregnated polymethylacrylate release, which has the advantage that it causes a sustained release of the antibiotic for 4 to 6 weeks. However, it has a disadvantage that it does not provide any structural support. It is difficult to remove after 4 to 6 weeks because of the ingrowth of granulation tissue, and being not biodegradable, it needs a second surgery to remove this. We have an option of antibiotic impregnated collagen sponges, which has the advantage that it is biodegradable, so it does not require removal. However, it does not allow controlled and sustained release, and at the same time it does not provide any mechanical support. We have an option of antibiotic impregnated cement nails, but in the market there is no synthetic antibiotic cement nails which are present, and it is prepared in the operation theatre with the help of a cement, antibiotic, and a nail such as Steedman pin, or like in our case, it was used, V-nail was used. So what is the rationale behind using any antibiotic coated cement nail? It elutes a high concentration of antibiotic at the site of infection. It provides the mechanical support. it fills the dead space, and it is easy to remove even after long periods because it generally has a smooth surface, unlike the beads. Now this was an indication which was given by Bhadra and Roberts, according to which he has used antibiotic cement nails for medullary osteomyelitis. Probably this is also a case of medullary osteomyelitis. Well managed with debridement, removal of the metal nail, and antibiotic cement nails. But any antibiotic cement nail has to be removed after 4 to 6 weeks, and we have to get a culture at that time. If the culture is negative, only then a definitive fixation in the form of intramedullary nailing should be done. And if the culture is positive, the entire procedure gets repeated. So in 2006, a new tibial titanium nail was introduced, which has a polylactic acid coating, which was biodegradable, and it was loaded with gentamicin. The advantage of this nail was that it causes a sustained release of antibiotic. The coating was biodegradable, and as a result, the second surgery, which is generally required in an antibiotic cement coated nail, is not required in this. So what are the principles of open fracture management? We have resuscitation, because most of these open fractures are seen in the setting of a polytrauma, like in our case. So we have to first follow the resuscitation protocol given by ATLS, airway, breathing and circulation. Then we have to go for wound management, which involves debridement and irrigation, tetanus toxoid, prophylactic antibiotics, fracture stabilization, wound coverage and functional rehabilitation. Adequate debridement is the single most important factor in achieving a good outcome in open fracture. And it should be done in a systematic way, starting from superficial structures, from skin, subcutaneous tissue, muscles, and then bone. If required, the wound extension should be done for full evaluation. Tourniquet generally should be avoided because we assess the viability by the bleeding margins. So if we apply the tourniquet, we will not assess the full viability. And when it is difficult to determine the viability at the initial debridement, it should always be repeated after 24 to 48 hours. Then comes the irrigation, which is a supplement to a systematic debridement. According to Anglin, at least 3 liters of fluid are required for irrigation of type 1 fractures, 6 liters for type 2, and almost 9 liters of fluid is required for type 3 fractures. The most commonly used fluid is Ringer's lactate or normal saline, and we should always avoid high pressure pulsatile lavage for irrigation because that can drive contamination into the hidden depths of the wound. The timing of debridement and irrigation is controversial. Most of the guidelines they recommend within 6 months. However, the literature is contradicting. Prophylactic antibiotics is an adjunct to meticulous debridement. Bacterial contamination is almost always present in open fractures. There is a strong evidence for the efficacy of first generation cephalosporins. For type 1 and 2, we use first generation cephalosporins. For type 3, we add an aminoglycoside. If there is a farm or agricultural injury, we add an anaerobic cover such as metronidazole, and the duration for which it is given only for 48 to 72 hours. Then comes the fracture stabilization, which has to be done at the same setting of debridement and irrigation. Why an early stabilization is required? Because it will protect the soft tissue from further injury by fracture fragments. It will improve the wound management, and at the same time, the joints can be mobilized and the patient can be mobilized as a whole. We have multiple options depending upon the fracture and the soft tissue injury. We can use either an intramedullary nailing, we can use an external fixator, either a tubular fixator or a ring fixator, or we can use plates. As a general rule, for low-grade open fractures like for type 1 or type 2 fractures, the treatment is just like a closed fractures, and intramedullary nailing is the treatment of choice. However, for more severe open fractures like for type 3 fractures, which require repeated excisions of the soft tissue management, external fixation is preferable. An external fixator can be applied both as a temporary or a definitive measure. If we are using an external fixator and during the soft tissue management we see that the callus is appearing, then it can be used as a definitive measure also. We can dynamize the external fixator at that time and start partial weight bearing. If the fracture remains ununited even after soft tissue healing, then the fixator has to be removed. We should allow some time, around 4 to 6 weeks, for the pin tracks to heal, and then the definitive fixation in the form of interlocking nail or ring fixator should be done. As far as plates are concerned in open tibia fractures, they generally do not have any role because of the increased incidence of superficial and deep infections as compared to the other nailing, compared to other techniques like nailing or external fixator. Soft tissue coverage should be performed within 7 to 10 days if possible. Type 1 fractures can be closed primarily, while type 2 and type 3 fractures they can be dealt with delayed primary closure. Type 3B fractures, they require either local advancement or rotation flaps, and split thickness skin grafting is suitable for coverage of large defects with underlying viable muscle. In proximal third tibia fractures, they can be covered with a gastrocnemius rotation flap, while middle third fractures, they can be covered either with a soleus rotation flap, and in general, distal third fractures are usually covered by a free flap. Then comes the functional rehabilitation, which involves the range of motion exercises for the nearby joints like knee and ankle, muscle strengthening exercises, and then full weight bearing once we see a breaching callus on the x-rays. So in summary, all open fractures are surgical emergency because they are potentially limb-threatening. Debridement is the single most important step in the management. Systemic antibiotics, they have a limited efficacy in the presence of implants. Local antibiotic delivery systems, they can be used as a staged procedure for intramedullary infection. And if we have used antibiotic impregnated beads and nail, it should be removed after 4 to 6 weeks, or they can themselves be a source of infection. So always remember, sterility of a bone once lost is never regained. Thank you. We are open for discussion.
What are the common awareness given rise to when you have these kind of fractures? What is the common awareness?
So mostly the skin flora is implicated. So mostly we have staph organisms, mostly staph aureus, staph epidermidis.
Finally, what was the outcome of this patient?
He is still coming to our OPD with the same complaints, and we are waiting for the operation theatres to start. because he has undergone almost 3-4 surgeries, so he doesn't want to take any further risk. So he is staying with us.
So you are planning an external fixator for him? And
we are planning to remove the infected nail, debride. We have to do whatever I have said, and then if required, we can go for a soft tissue coverage and an external fixator. Ring fixator we are planning.
So if you were to treat this patient, he would have come to you in the beginning.
Yes, sir.
How would it have been different from the way it was treated?
So the first, after the life-threatening injuries which was taken care of, it should be debrided as early as possible. The timing is controversial, but it should be debrided. The timing in this case was 3 days. So it possibly, if it is earlier, it may much be better. At that time, possibly the infection has already set in. So we should not go for any internal fixation at that time. So if this patient comes to us at an early stage, we can manage with a debridement as early as possible once the life-threatening complications are avoided. And then we start with a possible debridement and an external fixator at that setting. And patient will go a repeated debridement if required after 24 to 48 hours under the cover of systemic antibiotics. And then once the wound, if we think the wound is good, then after 7 to 10 days we can change the fixator and go for an intramedullary nailing. However, if the wound is not right, the fixator can be continued, the wound can be managed with repeated dressings, and once the wound is healed, at that time we will assess the fracture union. If the fracture is not united, then we will go for a definitive fixation in the form of internal fixation, intramedullary nailing.
in the olden times when they used to irrigate these wounds, they used to add hydrogen peroxide.
Yes, sir.
Whereby is that stopped?
Because so when it was compared with the normal solutions, like even soap solutions, they have compared with antibiotic solutions and hydrogen peroxide or betadine, they have not found any difference.
Okay.
So
Indian studies.
Most of the same studies.
There's a difference in the load of the thing when you get in the West compared to what you see here.
Yes, obviously it's a different scenario, but the management is basically different. The type of injuries are basically the same. There also, because of the road traffic accidents, are very common cause of death. So there also the type of injuries remains the same, but the management may be different because they have a good pre-hospital care. While ours, the patient usually come after 3 to 5 days, and then the management changes entirely.
So no hydrogen, no betadine, nothing is used, just plain.
Just plain normal saline, but you should use at least 3 liters for type 1. So whatever, we require a good amount of saline and under the antibiotics cover.
I think with the infection, if you look at peritonitis also, when you say when you open somebody with peritonitis, at the end they said you must wash with liters and liters of water or saline.
Yes.
To whether you use betadine and don't use betadine, that is there, but it has to be
Thorough irrigation.
very, very thorough irrigation.
Yes.
Why cement? Why cement and why this case?
Basically, the cement is a new technique, and the cement which has been, if the fracture, for us, it is a good thing that the fracture has not united. Because if the fracture has united, then it will be very difficult to remove the entire intramedullary cement which is present. You might have to require a splinting of the, you have to break the bone and then remove the cement. So, since the bone has not united and possibly there is an infection, we can remove the cement through that side.
But what is the correction of shortening?
Shortening of 1 centimeter is dealt with only some kind of heel raises. However, if we apply a ring fixator, which I have told, at the same sitting we can go for lengthening also.
This is what Elazarov.
Elazarov.
There's something new which has also come, which Elazarov didn't do it. It's the fixators are not tubular.
So monorail fixators are there.
There's something is there.
So monorail fixators are there.
German
which is
guy
a,
or British guy or something.
There are two things in the market. One is a monorail fixator, the other is a Taylor spatial frame. So the Taylor spatial frame is essentially a very short spanning ring fixator which does a three-dimensional correction. But one has to have it has a learning curve of its own. But the monorail fixator or the Wagner's fixator is used as a monoplanar fixator which one can lengthen. But the rotational control is not very good. And the other thing which is coming into the market has started in Singapore by an Indian guy is that they lengthen over a nail. So it has a device, it's an expensive implant, it can be put inside the bone and it transmits signals so we can lengthen on a nail and monitor the lengthening which is achieved. But that technique has been reported to have a very high incidence of deep infection and has worked in very limited number of hands.
But I think Elazarov has really changed the way these fractures get treated.
I think it is the only option. If you have multiple problems, like in this case, we have an infection, we have a shortening, although it is only 1 centimeter in this case, Elazarov is a good option.
So this antibiotic implanted beads, what is the cost?
It will, normally these beads are also made in the operation theatre. With the help of either an antibiotic cement, we generally get a plate, molded plate from the company. So in that we can put the cement, allow it to harden on the vicryl or a metallic suture, we can put that. So it is.
What is the thickness of that bead?
It will be around 0.5 centimeter or something.
It cannot be used in facial bones.
I have no idea.
For facial osteomyelitis also these beads are used, they are smaller size. But as you said that we have delayed the surgery till operation theatre start, will that really not compromise the ultimate result? The osteomyelitic process will continue to
Yeah, it will continue. Basically, the treatment, we are allowing the patient to go. It is not like that we are holding that patient to stay with us, but it's just like the patient has already undergone almost 3 surgeries at different places and he is not satisfied with that treatment. So he wants to stay with us, but yeah, surely the infection will proceed and it can have complications. That is sure.
And you said the mandible fracture was treated with, it was written ORIF with wire osteosynthesis. That site is completely normal? Because
I don't know,
wire
basically
osteosynthesis-
he has no reports of any mandible fracture or CT scan which we have asked for. Because he has no reports of any records, but he just said that कुछ wire डाला था इसमें और अभी ठीक
If
है.
it is an ORIF, open reduction with wire osteosynthesis, it itself is an inadequate stabilization. There are very high chances of
We will
osteomyelitis
refer the
there.
patient to dental surgery for further evaluation. Because this time he has no complaints, so we have not assessed that.
No, they've given him the option that if he wishes to undergo this surgery, he can undergo, but I think he has faith in Jalan and Abhay and he wants to get it done here. That is what it is there. Now, what sort of an operating room would you like to operate this patient in? Where you would do all your infected surgery or where you do all your clean surgery?
No, it will be a clean surgery possibly, sir. Because once there should be normally what we do, if we have an infection, gross infection, the entire first surgery is done by a set of instruments and a surgeon who does the debridement, who does all the things which is required for surgery. And then another set of instruments and trolleys are set up with another set of surgeon who does the second surgery.
So the question, the reason was the concept that was there that this particular OT is only for doing infected surgery versus this is only for doing clean surgery does not hold good these days.
Yes, sir.
Within a minor flow system, I think it doesn't make any
It doesn't make
difference.
sense.
One can do a joint immediately after a infected patient.
But the clean cases have to go first.
Yes, sir. Clean cases has to be done first, and then it has to be done by different sets of surgeons.
So do you use hydrogen peroxide at all or not? Or you
We are not using it.
or betadine?
We are not using in the acute setup. If there is a necrotic slug which we are not able to remove, then we are using it. Otherwise, in an acute setting with an open fracture, in the emergency we are not using it. Hydrogen peroxide or betadine.
And what about this continuous irrigation? At times they also have people use with betadine.
Continuous irrigation is not recommended like say for open fractures until unless it has been done earlier, but now it is not much used. It is not used commonly.
We do it as of today. We do it for draining wounds, in which we establish a continuous suction irrigation system, so that try and create a closed compartment, so that from one end we have continuous flow of fluid and the other end we have an output. The problem with such tailor-made suction irrigation systems is that they get blocked very often and they tend to create a compartment. And unless we've done an adequate debridement, it doesn't really work. So those things will work only if in the background of a very adequate and a thorough debridement.
Now what if the patient asks you that what is the probability of my surgery being a success or a failure? What would you tell him?
That is a difficult statement to make because
No,
we
that's
have
what he
we
said,
have
I
already
found-
prognosticated the patient because of the infection. It is very difficult to limit that infection and predict that further there will be no infection. So it is a very difficult statement to make that what are the chances that the patient will not have any further episodes of infection. However, if we have a good debridement, we can expect healing of the bone as well as the.
So he says, what probability would you give me in terms of my recovering from this versus still having an infection and not having a complete healing there and discharging?
Almost 50%.
Removing the semen must not be an easy job.
Yes, sir. Yeah, removal of cement is not very easy. We have special set of instrumentations for removing the cement.